This presentation will cover an overview of pain management. Throughout this presentation, we'll be talking about how to define and measure pain, the difference between addiction, dependence, and tolerance, and we'll briefly cover the common therapeutic options and treatments for pain. Defining pain can be difficult because it is patient-reported and it is very subjective. Some definitions of pain include an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or a body's way of sending a warning message to the brain that something is wrong. Ultimately, pain is whatever the patient says it is because pain is very subjective. There are some tools and techniques used to assess and score types of pain. One example can be seen here, which is called a visual analog scale, where the patient either by the number or by the photo that identifies what their pain is, says what their pain is on a scale of 0 to 10. Other scales use things like activities of daily living, so it measures how frequently your pain interrupts your ability to do things like dress yourself, or how frequently your pain limits your ability to sit or stand for periods of time. These scales can be helpful for assessing patients' progress or improvement over time with a more standardized measure. Another way to assess pain is through the patient interview or conversations with the patient, and there are two mnemonics that are helpful to assess pain. The first is ABCDE, and this is more about the process you should use to assess and care for a patient. So it talks about assessing the pain, believing the patient about reported pain, choosing an appropriate option, delivering interventions, and empowering the patient. The second assessment is one that I see more commonly in practice, and this is the PQRST. And this is a mnemonic that's used to help remind you of important questions to ask when assessing a patient's pain. So palliative, provocative, or precipitating, so what factors are making the pain better or worse. Quality, having the patient describe the pain, whether it's dull, achy, sharp, stabbing, shooting. Radiation, where is the pain located and is it spreading anywhere? Severity, having the patient rate the pain or compare it to other kinds of pain. And then temporal factors, does the pain change over time, either throughout the day or longer periods of time, like does the pain change over weeks of time? There are many different kinds of pain, but they can be largely categorized into acute versus chronic pain. This definition is based on how long the pain has been occurring. Acute pain is typically less than 3 months, and it often has some sort of known trigger like rolling an ankle or resulting from a surface level burn. Usually acute pain responds well to treatment or resolution of the trigger or precipitating event. Chronic pain, on the other hand, is pain that lasts longer than 3 months. Sometimes chronic pain can have a known trigger, but sometimes chronic pain may not have a trigger or may be caused by an ongoing cause. Chronic pain may be responsive to therapy, but the pain may continue or get worse or persist even despite therapy. Next, we will cover some common terms associated with pain and the treatment of pain. First is addiction. Addiction is often associated with opioids, but addictions can occur to other medications besides opioids. Addiction is related to a compulsive use of the drug for reasons other than pain relief. So for example, if someone takes an opioid regularly for chronic pain issues, that does not mean they are addicted. However, if they are using the opioids outside of the way they were prescribed or in the absence of pain, this may be a sign of addiction. This may be considered more of a psychological dependence where the person feels that they need the medication to function, even in the absence of pain. On the other hand, physical dependence is when the body becomes dependent on the drug. Without the drug, this can lead to withdrawal symptoms. This can happen if the opioid is abruptly stopped, if the dose is reduced, or if an opioid antagonist is administered. Signs of withdrawal include tachycardia, sweating, body aches, nausea, vomiting, restlessness, and insomnia. Physical dependence can occur during normal use of opioids, but it is often associated with addiction or abuse of opioids. Finally, tolerance is the decrease of a drug's effect over time. This means that the body requires higher doses to maintain the original level of pain relief. This is a natural effect of opioids, and tolerance is not the same as addiction, or is it a predictor of abuse. Tolerance to opioids will happen to all patients who take them for an extended period of time. So for patients who have chronic pain, you see this especially in cancer patients, that their dose of opioids will generally go up just for them to receive the same level of pain relief. In some ways, tolerance can be a good thing because your body can become tolerant to some of the side effects of the medication. For example, the sedation and nausea caused by opioids generally goes away as patients are on them for a longer period of time. However, there are some side effects that your body will not become tolerant to, and that includes constipation and respiratory depression. These are concerns no matter how long a patient has been on opioids. As you can see, pain is a very complicated issue. You need to think about the differences between physical dependence and psychological addiction. Physical dependence, as we said, is when your body becomes used to having the drug in its system and it goes through withdrawal when the drug is taken away. Addiction is an added layer on top of dependence. It is a craving that often occurs and leads to destructive behavior in order to satisfy the craving to get more of the medication. Some patients become so fearful of addiction that they do not even want to take opioids as prescribed. It's important to address these real concerns and help patients understand the difference between dependence and addiction. As we said before, tolerance is also a natural process, so we shouldn't be afraid to increase a patient's opioid dose to achieve optimal pain relief. This image is from the World Health Organization, and at the top it says that it's specific to cancer pain, but really this stepwise approach is appropriate for a variety of possible pains. In general, the approach is broken down into 3 steps. The first step is for mild pain, or kind of the initial treatment, and you want to be thinking about non-opioid medications and potentially adjuvants. Adjuvants are add-on medications, which we will talk about at the end of this lecture. But in general, this step 1 is going to be your OTC type pain medications, such as Tylenol or ibuprofen. Step 2 is for pain that did not respond completely to the first step, so you're going to start thinking about mild opioids like codeine or tramadol. Tramadol is a weak opioid that previously was not a controlled medication, but in the past few years has now transitioned to be classified as a controlled medication. Finally, step 3 is the stronger opioids, and that includes things like morphine, oxycodone, and fentanyl. Throughout all of these steps, you also want to be thinking about non-pharmacologic treatments, such as rest, heat, ice, compression, physical therapy, stretching, and etc. We ultimately want to fix what is causing the pain if possible. We want to treat the underlying disease or disorder and not just mask the pain with medications. So breaking down these categories of analgesic classes a little further, you have your non-opioid or non-narcotics, and this includes your non-steroidal anti-inflammatory medications, and these are your ibuprofens and naproxen. And then you also have acetaminophen, which is Tylenol, or aspirin, which is sometimes called ASA. Aspirin is generally not a preferred method for pain relief because of the side effect profile, but some patients do like to use it and find relief from it. We've talked about these OTC medications in other presentations, so we won't spend too much more time on them today. We will focus mostly on the opioid narcotic medications and touch briefly on the adjuvant medications. Again, adjuvant medications are used to enhance other pain medications or used instead of traditional pain medications. They generally work by different mechanisms than the traditional pain medications, and they do not target traditional pain receptors. Opioids can be broken down into mild opioids and stronger opioids. Mild opioids are used for mild to moderate pain, but remember that pain is very subjective, so it's difficult to really classify what mild to moderate pain is from patient to patient. Opioids work on the mu receptor, which is a pain receptor. The mild opioids target the mu receptor, but have a lower affinity than the stronger opioids. They are effective, but less potent, and generally have a lower potential for abuse and addiction. The stronger opioids are generally reserved for moderate to severe pain. They have stronger affinity for the mu receptor, and an example of a stronger opioid, again, would be oxycodone or fentanyl. These are controlled medications because of their higher potential for abuse and addiction. As we said, opioids target the mu-opioid receptors in the central nervous system. Because these receptors are located in the central nervous system, this provides pain relief, but it also can cause sedation. The medications are not fixing the source of the pain, but they are altering our perception of the pain and limit the pain that we are feeling. In general, opioids as a class of medications carry many similar side effects. Opioids often cause nausea and drowsiness, but these are side effects that the patient can form some tolerance to if they are on opioids for an extended period of time. However, there are some side effects that we cannot develop a tolerance to, and this includes the constipation and the dry mouth. You may remember from the constipation medication presentations, but opioids actually slow the motility of the GI tract, which is what leads to the constipation. So patients are often started on a stimulant laxative when they start opioids to maintain the movement of the gut to promote regular bowel movements. There are some serious contraindications or precautions with these medications. The biggest is probably respiratory depression. This is rare but very serious and can lead to death. This concern becomes greater with stronger opioids at higher doses, but also is a concern in patients who are new to opioids and have a low tolerance to the medication. Additionally, elderly patients often are slower to metabolize and eliminate these medications due to renal or hepatic impairment, so there can be buildup of the medications that can lead to more side effects. Especially in the elderly, we worry about fall risk, so dizziness and drowsiness caused by these medications is a big concern in the elderly. Also, as we've talked about, there is potential for these medications to be abused or misused, and that can also lead to serious consequences. The use of opioid medications is increasing at an alarming rate, and the use of opioids in the U.S. is very high. Americans make up about 5% of the world population, but consume 80% of the world's supply of opioids, and specifically, we consume about 99% of the world's use of hydrocodone or Vicodin. Since 1999, the deaths from opioids have more than quadrupled, and heroin, which is an illicit recreational opioid, 3 out of 4 heroin users report that they started abusing prescription opioids before they switched to using heroin. So opioid abuse is a big concern, and it is a national public health crisis. The following list includes recommendations from the CDC to prevent opioid overdose deaths. Prescription monitoring programs are used by pharmacies and doctors' offices to track prescriptions for controlled medications. This way, pharmacies and prescribers can see how often a patient is filling prescriptions for these medications, and if they are using several different doctors or several different pharmacies, which can often be a red flag that the medications are being abused or not used appropriately. Also, the CDC recommends education and improvement of opioid prescribing to limit the use to only when necessary and to try the other options of the steps first, and also to increase access to substance abuse treatment programs. Another recommendation is to increase the access to naloxone, which is a medication that is used to reverse opioids in an overdose. We will talk about that next. So the use of naloxone could be a presentation in itself, but we will briefly highlight it here and talk about the role that pharmacists have in the use of naloxone. Naloxone is an opioid antagonist, so it binds to the opioid mu receptors that we talked about, but it blocks it so that opioid medications cannot bind. This binding of naloxone, also called Narcan, rapidly reverses the effects of other opioids. It's available in several forms and is often carried by paramedics and used in the hospitals as a vial that gets injected with syringes. However, there are 2 forms that are available for the general public to administer, and one is an auto-injector, so that's a kit similar to an EpiPen, and also a nasal spray. In Minnesota, naloxone can be dispensed by a pharmacist without a prescription. However, the specifics of how this law is applied varies from pharmacy to pharmacy. The pharmacy must have an agreement with the prescriber to create a standing order, which means that the pharmacist is allowed to write a prescription under their name for the naloxone, and then the naloxone can be dispensed. It can either be dispensed to a person who is using opioids who is concerned about an overdose, or it can be dispensed to a friend or family member who is concerned about someone they know overdosing on opioids. It's important to note that this medication is only effective on opioids, so it won't work on overdoses from other medications. It's also important to know and counsel patients that if they need to administer naloxone, they still should be calling 911. This is because often several doses are needed and monitoring is very important. This is a very simplified overview of naloxone and the pharmacist's role, but I encourage you to learn more about it on the Minnesota Department of Health website. Adjuvants are medications used for pain relief that target different mechanisms or receptors. They can have therapeutic effects alone or can be used in combination with more traditional pain medications. None of these medications work on the opioid receptors. Some work on GABA receptors, others on histamine receptors, or with neurotransmitters such as serotonin and norepinephrine. These neurotransmitters work in the brain to provide different pathways for pain relief. Some of these medications we have covered in other presentations throughout the semester. This list is provided just as a reminder that pain is very complex and often requires treatments from a variety of approaches to provide adequate relief. Let's take a look at a patient case example. Anthony is a 57-year-old male who has persistent knee pain from running. He has no known drug allergies and he has an ACL repair surgery and is discharged on an opioid. What are some common side effects that we might want to talk to Anthony about with his new medication? We want to warn Anthony about constipation and maybe start him on a stimulant laxative or at least encourage him to increase his fluid intake. We also want to warn him about the potential for nausea and encourage him to take it with food if it upsets his stomach, and also warn him about drowsiness and dizziness and tell him not to drive while taking this medication. We also want to warn him about the risk for respiratory depression while taking this medication. We went through pain management pretty quickly in this presentation. It's very complex, so in many ways this was oversimplified for the purpose and level of this course, but there are some very important key takeaways. Pain can be defined in many ways, and it is subjective to how the patient reports it. There's a difference between addiction, dependence, and tolerance. And it's important to know that there are many options to treat pain, and we should think about treating pain in a stepwise fashion. On the next slide, there are a few resources if you're interested in learning more about pain treatment.